Good evening and welcome to the Rural Medicine Grand Rounds. I'm Dr. Lucy Ingram. Tonight we have two fascinating cases highlighting the challenges that rural doctors face when dealing with mental health issues in the bush. Discussing the first case tonight, we have our panel of experts consisting of Dr. Blair Koppen, Medical Superintendent in Warwick and General Practitioner from the Australian Rural Leadership Program. We have Dale Batzloff, Mental Health Nurse Practitioner and Educator for the Southern Queensland region. Welcome, Dale. And also Mr. Harry McCay from Head of Professional Conduct from AVANT Queensland. Thanks, Harry. Please welcome our specialist and expert panellists. As usual, we are being live streamed around Australia. We have a number of participants watching remotely, so I encourage you all to join the discussion by emailing your questions to grandrounds@qrme.org.au or use the hashtag on your screen now. So our presenter for tonight is Dr. Terry Cheng from Warwick Health Service, and his presentation will be on depression in rural general practice. Please put your hands together for Terry.
Thank you, Lucy. My name is Terry, and I'm currently doing my first year primary rural training at Warwick Hospital through my GP training provider, QRME. Today, I'm asked to present a case which is very relevant to our rural practice. Don is a 55-year-old rural farmer. He lives on a rural grazing property with his wife and a disabled son. The main presenting complaint of Don was he was confronted by 5 men pig shooting on his property. This happened twice in the past 3 months. And he was threatened by all these events, and he thought if he laid charges on these people may take revenge and potentially damage his property and even killing his livestock. So as we all do, Don went on to check on the Facebook, and he found the leader of this group is a dangerous man. He is a drug dealer. And when Don found out all this information, he was quite shaken and teary about all this. Now, Don is constantly thinking about these events. It starts to affect his sleep and also giving him nightmares. He is feeling irritable during the day, and he has lost appetite and interest in other activities as well. And he was constantly thinking about this man could potentially harm him and his family. He cannot think of a way out, and he is starting to have suicidal thoughts. But at this stage, he has got no plans or intents. But he does have guns on his property, which is quite common to a rural setting. For Don, trying to do day-to-day tasks has become difficult. He is quite often crying, shaking, and feeling anxious. He does, however, seek advice from his solicitor, and he finds out the cost of preventing this man from entering into his property would end up costing him $60,000. And also on top of this, Don is also under stress of some court case in the Supreme Court over some debt issues, as well as he's being sued over a real estate business. So Don is under quite a number of multiple stresses at this stage. Don doesn't have any medical history, and he is not on any regular medications. He is not allergic to anything. However, he had a conviction about 25 years ago, and because of the illegal possession of firearms. He doesn't have any psych history. He was quite a well man before all this happened. He married 5 times in the past, quite a lucky man. And he has 6 children from 3 marriages, and he is still keeping in touch with 3 of his children. But he sort of lost touch with the others because he does not approve with their lifestyles. So Don is quite a heavy smoker. He smokes about 50 cigarettes a day and occasionally drink a couple of drinks, and he drinks a cup of coffee a day. So we did a mental state examination. His appearance was quite a typical of a rural farmer, wearing leather boots and a bushy hat. He maintains good eye contact throughout the conversation, but he was quite upset and agitated at times and tearful at times as well. His speech was a bit subdued, refined, and pressure at times, and when talking about all these men potentially causing him harm, but his tone was normal and his volume was also normal. His mood was depressed as well as anxious. He had this feeling of hopelessness and also frustrated about himself. His affect was reflecting his mood. He was quite agitated and tearful at times. His thoughts were quite occupied with feeling of hopelessness, and he was quite frustrated about all these court cases pending, and how these court cases is going to impact on him as well as on his family. His perception was mostly negative, but he has no perceptual disturbances. He was oriented to time, place, and person, and his insight was limited, and his reasoning was poor. So we did a risk assessment on him, and he is at risk of harming himself. He does have thoughts about cutting his own wrists, and he also has, like I mentioned before, has guns on his property, and he is at risk in the context of unexpected events, basically impacting on his mood at the time. So it's quite unpredictable. So looking at Don, his symptoms are quite consistent with adjustment disorder because he is under multiple stresses. You could also argue Don maybe also can be diagnosed with a post-traumatic stress disorder because he is constantly reliving the traumatic events in the past. And also he has symptoms of anxiety as well as depression. So in terms of the management, he was prescribed with some sedatives to help him to sleep better. And also he was referred to see a psychologist with some cognitive behavioral therapy. And also engaging him with multiple regular health checks. And also a referral has been made to ATOS trying to help him to quit smoking. Don was quite antidepressants. And he sees taking this medication as a weakness, and also it's more like an admission of being mental. But he did agree to have a trial of antidepressants, so he was prescribed with AVANT, starting off with 15 milligram Noctay, and then gradually increased to 30 milligram. So on the next appointment, he did not attend. And so we did a phone follow-up, and he did admit to us that he stopped taking the antidepressants 5 days ago. And because he thought the medication was causing him feeling drowsy all day. And also he is quite still very reluctant to take medication because he thinks the medication is only for the weak people. However, he did agree to attend the cognitive behavioral therapy sessions. Basically, the psychologist is helping him to focus on what he needs to do for himself in order to help his recovery. And, instead of focusing on other people. And he did manage to agree to start another type of antidepressant with less side effects. So we prescribed him with fluvoxamine, basically starting off with 50 milligram and then gradually increasing to 100 milligram. So on the next appointment, he reported to us that his mood has improved, and also his mind is quite clear, and he was quite calm. And also he has a sense of humor. he's starting to enjoy life better and the farm work as well. So, but the sleep is still remained poor, and he still has some ongoing anxiety symptoms. But he is now much less depressed. So we are still monitoring Don, and the case is still ongoing. So I'm going to hand over the following time to Lucy to start off with some discussion and questions.
Thank you very much, Terry, for your presentation. Yeah, so I think if we can perhaps start off with you, Dale, if I could ask you about the prevalence, you know, how prevalent is depression in rural Queensland?
I think the prevalence of depression is very hard to gauge accurately, given that
Yes.
we, in rural areas, whether people actually seek help is another huge question. I can talk about the statistics for suicide
Yes.
in rural and remote areas as opposed to metropolitan areas, and they are staggeringly fourfold in rural areas when compared with metropolitan areas. Also in gender-specific comparisons, the suicide rate for males is 3 times that of females as well. So very, very high incidence of it occurring. And of course, we have all of the cultural differences out in the bush, the male stoicism, the droughts, the rural poverty, financial hardships, particularly like with Don in his case. Here is a classic example of a farmer, and the levels of distress or pressures that people are under in rural areas.
And if I could perhaps ask you, Blair, to sort of further comment on that as well with this kind of presentation. I mean, I noticed there was a risk assessment done on Don, and he was thought to be quite high risk because of impulsiveness. So if you can just flesh out for the registrars watching how you go about a risk assessment in your rural farmers and that population, and what sort of things do you look for that flag them as high risk?
Well, I think depression in combination with other factors, so those other factors may be alcoholism or heavy alcohol intake, drug taking, personality disorder, any past history of suicide or family history of suicide or suicide attempts, any incarceration, criminal behaviour, if there's domestic violence, any anger management issues, so basically those are the factors that I would, in combination with depression, be concerned about.
Okay, and so what do you do to kind of manage that risk where you are in Warwick?
Well, if you have a patient like that, I mean, I mainly see people through the ED, and it's a sausage factory, and I can't spend an hour with the patient. So I make a quick assessment and I hand over to Dale and the mental health team to do the full assessment and spend a long time with the patient.
Yes.
So personally, I don't spend a lot of time with the patient. So
yes, so if I can bring that across to Dale, because you're a nurse practitioner in a rural area.
Or a nurse educator. Yeah.
And nurse educator, yes. So can you talk a bit more about your role out there and what you do with these patients?
Okay, so basically when someone is referred to mental health, or they come as a self-referral, which is possible as well. We take referrals from anybody, from GPs, from the hospital itself, NGOs, whoever. They come through an initial assessment period where they're seen by our acute community team, and they do a full assessment, what we call an initial assessment or initial intake on that person. It's from that point that they begin to tease out possible diagnoses, if there is one, a full cross-sectional history of what is going on for the person at this point in time. Also a longitudinal look, which is very important, as you'd imagine, in mental health. We need to look at the longitudinal picture of their progression, I guess, to this point, or perhaps other factors which are influencing the outcomes of this this episode at the moment. So, and then from that point, it's decided whether or not they will benefit from what we call ongoing case management. Some people only spend a short period of time, usually a couple of weeks or so within our service. We then refer them either back to the GP for management or refer them on to other services, private psychological services and better access and programs like that. Of course, keeping in mind that the stigma of mental illness and a diagnosis is still very scary to a lot of people. So, so the more often that people are kept within their own community and supported within their own environment and their own support systems without the need for them to be hospitalised and whatever, then the best outcomes for everybody. Those of the people who require longer term case management then go on to case management, and we have specific teams to deal with child and youth presentations, adult presentations and older persons, and also we have an AODS worker as well who works in the district.
Yeah. You did mention stigma there, and that's something that did come up in the case presentation as well. What are your thoughts on that, particularly for perhaps, say, a rural farmer?
Very, very interesting to sit down and discuss. You know, I think there's still a significant stigma associated with mental illness in Australia and in most countries. We certainly seem to have more of a stigma in rural areas. Whether that's why that is, I don't really know, but I guess it's that rural farmer and the stoicism and the fact that they're the breadwinner and their properties have been passed down sort of one generation to another, and there's a sense of shame, a sense of embarrassment, you know, much like Don was saying, you know, I really need to just get on with it. There's that fear that they're a failure, that they're not living up to who they should be, they're not being a man, whatever. And of course then we see the incidence of male suicide is far higher across the board in all communities, but particularly in rural areas. These statistics for suicide from 2001 till 2010 have remained largely unchanged. However, when we've in the past sort of highlighted, as Blair said, young males and whatever in the high risk suicide category, it's now moved on to the 25 to 35-year-olds. So that's happened in recent years, and we have to stop and question, you know, why these things are going on.
Yeah. Blair, are you able to sort of talk a little bit more about what kind of attributes we would look for in a patient that would make them sort of high risk for, say, depression or suicide? You know, when patients are walking in the door and registrars are seeing them, what should they be looking for there?
Well, I suppose anyone with a pulse, anyone that's human, is at risk. But the big groups that we see in rural areas, as this case, middle-aged farmers, people that live at work, isolated, under often financial stress, disasters, floods, droughts, and access to means. So that's one big group. Another big group is young Aboriginal people. So with loss of culture, environmental factors, maybe access to petrol sniffing and alcohol. The third group is young males. They, again, may have substance abuse, alcoholism, and in small communities they may have same-sex preferences or LGBTI, and that may cause a lot of stress in small communities. Another big group is the carers and the older Australians, where you get into more the youth euthanasia group, sort of 80 plus, or someone that's caring for someone, that person has died, and that carer is at very high risk. And that's often the most lethal group, the most successful group in committing suicide. And the last group is health workers under a lot of stress, and this is probably the only group where females are more than males.
That's very interesting because, you know, doctors, I guess, aren't immune to the effects of depression, and in fact I believe that statistics show it may actually be higher in healthcare workers. So Harry, if I can ask for your input here, just for the registrar, sort of looking at home, if a registrar or a doctor is finding themselves, you know, with symptoms of depression or contemplating suicide, sort of what are your sort of recommendations for dealing with that, and implications for their practice?
Well, I think it's very important that every doctor has their own GP, and a lot of doctors don't. But that's a recommendation not just from AVANT but from the medical board and I think the College of Psychiatrists. You need to have someone who can objectively and professionally talk to you about any health issues and pick up where there has been a change and then suggest, you know, can it be worked through with psychotherapy or do you need pharmacotherapy as well? It's very important doctors don't treat themselves. We've had a situation where I acted for a doctor who had a problem with alcohol and did very well. Went to AA, was completely abstinent for 5 years, then had a breakup in a personal relationship and took a number of Normosin to deal with stress and anxiety. And the next thing he knew, he was at the Princess Alexandra Hospital, being treated with burns to his feet and being interrogated by police because he had started a fire in his girlfriend's house. The circumstances in which that occurred was very unclear because he was in a very foggy state. But it's very important not to treat yourself. You just don't know. You cannot judge the impact of medications. You need someone who can be objective about that. You can seek assistance from senior colleagues. And, you know, the other thing, and I think this is particularly the case in rural areas, people need to be able to share with spouses, particularly males. They're very poor in saying, I've got a problem. I was talking to a doctor today who has a significant legal issue and hasn't advised his spouse. And our advice is you need to be able to share that because that's a real source of support. And I know that they don't want to put stress in family, but by doing that they find another source of support. And, you know, if they need to take time off work, they need to take time off work, advise the medical board, and then just go through whatever treatment is needed to bring them back to full health.
Thank you. Yeah, and I think just sort of working on with that, was just going to ask perhaps Blair or Dale to comment about social isolation in rural areas and what impact that has on mental health of patients. Perhaps if Blair would like to start.
Well, I think first of all is limited access to mental health. There may be distances to drive. Once you're there, it's difficult to get in, so you may be waiting in waiting rooms for a long time. There's certainly very little in the way of specialist help, psychiatric help. There is nurse practitioners and there are psychologists, but maybe not psychiatric help. And if there is, then that's by telelink or video conference.
Yes.
I think it then gets back to social stigma. In a small country town, you may not want your business out in that small community. Whereas in a large city such as Brisbane or maybe even Toowoomba, you know, it's pretty easy to hide in a bigger city, and you're much more likely to present with your problems. But in a small country town, a lot harder, and especially if you're a farmer or, you know, it's a lot harder.
Yes, yeah. And Dale, anything that you wanted to add to that?
Yes, I was just going to comment, just thinking of some of the more remote areas that only have RFDS in
Yes.
service and don't have ambulance services because of the distances to travel. If someone's flown out via RFDS, then the whole town watches the plane
Knows
go
about
over,
it,
and
yes.
really confidentiality is you know, kind of out the window, you know, in a lot of cases. It can be very difficult for someone in those areas seeking help, and that fear of judgment and everything else. Yeah.
Yeah, so I think just going back to the medico-legal aspect, you know, this case fortunately had a happy ending. He was responding to treatment, but it could quite easily have gone the other way and ended in tragedy. And I just wanted, is there a high incidence of litigation in these kind of scenarios with perceived sort of, I don't know, lack of services or support for rural people by the medical profession? Does it come up much? Harry?
Surprisingly, I think most of our cases are actually from city areas. And I can only think of one case involving a rural doctor. And that was a case where a patient had recently given birth and had expressed some strange thoughts after the birth, and there was a concern about some postnatal depression. And then what really concerned the GP was that the patient said that she was going to take her daughter to visit her first husband who had died. And there was a sense that they were going to join the first husband. And she tried to persuade the patient to voluntarily go and see a psychiatrist and perhaps spend a few days in hospital just to be assessed and perhaps put on a treatment program. The patient refused. The GP was so worried about it that she called the ambulance, and the patient still refused and in fact attacked the ambulance officer. And the GP ended up giving her quite a large dose of Logactyl, I think it was, and then admitting her into hospital. And the patient then made a complaint that she had been basically assaulted and kidnapped. And that's really the only case that you know, have come out of rural areas. We've had a number of cases where the concern has been that a patient presents to a hospital and is seen in the emergency department, and after an assessment, and they go, you know, often they have a checklist and they try and work out a risk score, is felt to be satisfactory to be discharged, and in at least a couple of occasions I'm aware the patient has in fact gone and done something really horrible, like in one case laid down on a railway line and got run over. So there are cases like that. But we also find that some patients can harm themselves in hospital. You know, they're admitted and they go to extraordinary lengths despite quite high levels of care and observation. You know, one patient killed herself by tying a plastic bag around her head. You know, the self-strength to stop ripping it off when you start to asphyxiate must be extraordinary. And that was the degree of desperation there. And another patient took some very normal type items. She took some nail varnish removal fluid, poured it over her nightdress, and then set herself alight with a lighter she used to smoke, and caused significant harm that way. So even in hospital, people can suffer harm. But I think from the medico-legal point of view, it's a matter of making sure that you followed a good process, because certainly for civil claims, the test under the Civil Liability Act is a doctor is not negligent if they've acted in a way that's widely accepted as competent professional practice by respected practitioners. So as long as they have gone through a proper assessment, triage, and you know, a risk assessment is done, then the doctor should be able to defend a legal case if one is brought.
So your advice to registrars then, in terms of, you know, a lot of people sort of worry, am I doing enough, am I doing too much? Is it better to err on the side of doing everything, or is it, you know, what kind of...
Yeah, I think that's really difficult. The best defence really is good medical practice. My experience is that involves firstly trying to allow yourself enough time for whatever the situation is, and often issues develop because people are pressured and try and cut corners. So the first thing is, if you can develop a habit of just saying whatever the pressures are for this particular patient in this moment, I'm just going to make sure I work through the usual things that I would if I had an hour, and I'm going to talk, go through the situation. I think that's a very important thing. The other very important issue is making good notes, and so you note whether, some patients come in and the doctor speaks to them and tells the lawyer afterwards, certainly would have asked about suicidal ideation, but hasn't noted suicidal ideation nil, or whatever the situation is. Making good notes is just part of good practice anyway. And I think in the rural area, it's important to try and form as many connections and develop those communication skills, because, in the cities you can have the acute mental health team that can go to the homes, and I think in Warwick and other areas the teams are there, but if you go a little bit further out, they're either not there or it'll take a long time for them to visit, and you might need to have other connections, whether it's with police or with ambulance or someone else, that you can rely on and they can rely on you, that if you think there is a problem, you can ask them to visit someone and just say, how are you and what's happening.
Yes, that's very important.
So probably the other thing to add is, if things go pear-shaped, it's not just your name there in isolation. If you've discussed it with the mental health team, ring up a psychiatrist. If you've discussed the case, it always looks a lot better if it goes pear-shaped, rather than you just wearing it all on your own.
Risk assessment is never 100% accurate. It's as accurate as we can make it be, because at the end of the day we can't read people's minds. We can only use the tools that we have in order to assess risk. And I guess a few things that we use are the different type of risk factors. So we look at what are what we call the static risk factors. So these are risk factors that are unchangeable from the past or their sex. So if someone has attempted suicide or has an attempt or a family history, like Blair was saying, or if they've had significant stressors in the past that have led them to a particular type of behaviour, then that is a static risk factor. The fact that they're male, the fact that they're Indigenous, all those things are static risk factors, and they're unchangeable. And then we have dynamic risk factors, and dynamic risk factors are, we're looking at the individual now, so that's the cross-sectional view of what is happening for them now. So we assess things like the means, the access to the means, the method of potential harm to themselves or to others as well. So all those things are involved in risk assessment, and also very importantly is the protective factors. So, as Blair was saying, as you were saying, you've gone through all of your steps in looking at, what are the risks at the moment, but then you've also looked at, okay, well, they're at home, their partner knows what's going on, they're a regular member of a community group, they've come to the emergency department or to the GP's office willingly and seeking for help. So all those things are protective factors as well in making that overall risk assessment.
That's very good. That's very useful, I think, for people out in, in the rural areas to be able to bring all that together and to be able to use that to do a risk assessment. Yeah. I thought we might sort of see now if there's any questions from the floor and see if there's anything that people wanted to ask the panel about this case or about any other cases they may have come across. Don't be shy.
Hi, my name is Andrew. I'm a junior doctor here at the Toowoomba Base. We've mentioned telehealth a few times here, and it strikes me as an area that could potentially be could utilise telehealth very well. Do any of you have much experience with it? And if so, have you found that they're, given the kind of intimate nature of the relationship between the psychologist, the psychiatrist and the patient, does telehealth create a boundary in your experience, a barrier in your experience that makes perhaps using this technology a bit more difficult?
Well, we use telehealth in geriatric ward rounds, obstetric, antenatal, with cancer patients. I think the only drawback with telehealth is the resources. It draws on the resources of the rural hospital. So we have to have everything set up. Everyone's waiting on our side, and then the specialist at the other end just wants to put on the switch and just be ready to go. So it really draws on the resources of the small hospitals. However, when you don't have a specialist, it's still a lot easier to do that than for the patient to go down and sit in waiting rooms and whatever. So I think from that point of view, it is a resource, but it does drain the staff at the small hospitals. I'll hand over to Dale to maybe answer in specific whether telehealth is used in mental health.
Yeah, we use telehealth in quite frequently in rural areas. We don't have full-time psychiatrists or psych regists out there, so it's just part of our everyday business. What we have found is that I've just been involved in a project which is actually doing after-hours telehealth strategy, putting that in place for some pilot sites in this area as part of the Darling Downs region. So that's for specialist after hours access to a psychiatrist in Toowoomba, etc. And it's working very, very well. So the staff in rural emergency departments are being supported. They're actually feeling like they're being supported. They're getting that expert assessment and opinion. As far as telehealth itself goes, there's a lot of studies out there as to, particularly coming from America, because they've been using it for quite a while as well in mental health, in psychiatry, that there aren't any huge sort of barriers to it in forms of assessment. I guess when we're looking at the mental status examination and we're looking at appearance and behaviour and things like that, there might be a few details that we would get face-to-face that we wouldn't get through telehealth, and certainly that rapport development and you know, having empathy with someone is obviously going to be much better established face-to-face. But those are sort of the realities of a rural or a remote area, that we sort of have the option to use it, and it is the only option for us at this point in a lot of cases. Yeah.
And I believe also with telehealth, there has been some incentives in place for general practice to make use of telehealth. However, those are starting to dry up sort of towards the middle and end of this year. So if you are interested in getting on telehealth, get on quickly. Yeah. Any other questions from our studio audience?
My name's Hayley. I'm a medical student at UQ. In the case study here with Don, we didn't actually talk about the risk of harm to the perpetrators here, the trespassers, and just like a comment on that, and also how much violent crime in rural areas might be due to untreated or unrecognised mental health problems.
Okay, so maybe I could answer the second question. I think male and female depression presents differently. So with female depression, it's how you feel. With male depression, it's how you act. So male depression can be masked with adrenaline-like activity, from wheels to work, sex to sports. You can resort to being a workaholic, to sporting activities. Can maybe masked with domestic violence, with road rage, all those sort of things, anger management type issues. So you may not feel, you know, have the typical teary-like expression. So male depression is often undiagnosed. And I think that may be part of the reason why the suicide rate is higher. Sorry, what was the first question again?
Just about the risk assessment, for the perpetrators, given that he was ruminating on those episodes of them coming onto his land with guns, pig shooting, and felt traumatised by that.
Yeah, when we do risk assessment, we actually look at a number of different risk areas. So we look at the suicide risk assessment and risk of self-harm. We also look at the risk for potential for violence or aggression. So he would have been very carefully looked at there, given the fact that he had access to guns on his property. You know, in the past, albeit 25 years ago, he was booked for having guns without a licence. That'd be a fairly common thing in a rural area back then. Perhaps if that was a little bit more recent, we might be a little bit more concerned. But a lot of his intention was, it was never verbalised. He was never said, I'm going to shoot them or I'm going to do this, and he didn't act on that. He actually went to a solicitor, which is a very appropriate thing to do. I think if someone was going to set traps or whatever to catch the perpetrators and whatever, we would have been more concerned, you know, about the risk that he posed to those there. But risk assessment is a continual ongoing thing that is done at every meeting with a client. So whether it be face-to-face, via the phone, via teleconference, whatever, a risk assessment is done every single time along with the mental status examination. So we have a fair idea of what is actually going on for that person and what risk they pose to both themselves and their others at any point in time. Or we try to. Yeah.
That's an excellent question. Yes. Just get a microphone to you there. Okay.
Just to go on with your question there about the aggression towards others, a lot of the information that you had there was no indication that he actually expressed his emotional distress aggressively. It actually was more personally focused. So he was wanting to cut his own wrists, he was withdrawing, those sorts of things. So there was no indication to suggest that he was going to act in an angry manner from that information. Mind you, he did have 5 wives. We don't know why they ended. There could have been some domestic violence, etc. But the information would suggest that he doesn't express his hostility.
My name's June. I guess I've got probably a slightly different focus question for you. In the aid package that was announced yesterday by the federal government, where they talked about there's, I think, $330 million being announced as drought aid, and a certain proportion of that, and I believe it's quite a significant proportion, is targeted at mental health. What would your viewpoint be? Is a lot of the depression that's currently around, is it situationally triggered by the stresses of loss of markets and droughts? And in that case, if it was down that track, are you better off channeling the aid into the mental health, which is certainly important, or is it going to be equally relieved by having decreased financial pressures?
That's a good question. I think it was 11 or 12 million was the figure that was quoted, but at this stage we don't know where that's going. We don't know into what services, whether it will be government, whether it will be private, NGOs, etc. Good point you make there. I think the drought's already here. The drought's been here for a while, so we are going to have some sort of emotional fallout. We already have in the far west. We've just gotten rain this week, in the last couple of weeks, in the Channel Country, which is fantastic and will certainly ease the burden of a number of people. However, I think the need for mental health support in whatever form it comes in from this package will be more than welcomed by the communities out there. I can see your point too in, fixing the problem, the solution rather than sort of putting the money into the outcome, But I think the outcome's already there. I think we've had a lot of unfortunate suicides and things already happening. I think it's was the percentages now in Southwest are sitting around, I think is it 70% of it has been drought declared or something or other. So, yeah.
Certainly after a disaster, in the first day or two you get the acute injuries after cyclones or massive floods or whatever, and then in the next couple of weeks it's probably GP type work as people try to clean up, fixing lacerations and stuff like that. But then for months afterwards it's really the mental health team that are trying to support the community and trying to give this rattled community some form of resilience to just get them through. So I think it's different phases that you have to look at that need support.
After major disasters, there are a number of teams. It's usually that Queensland Health sends out. They have funding for recovery, what we call recovery and resilience teams. But as we were discussing earlier, they'll go out for a period of time until the funding runs out, and then after that point is often the crunch time. Yeah.
Very good. And we've actually had a question come in from one of our remote viewers. It's more directed sort of at Harry about confidentiality in these cases and when it's appropriate to actually breach that confidentiality, perhaps if you feel that the patient is high risk for harm to themselves or perhaps to others.
Yeah. Well, under the National Privacy Act, there is a specific exception to the duty of confidentiality, which is that if a person poses there is a serious risk of harm to any individual, then it is appropriate to disclose information to try and avoid that risk of harm. So an example that happened last year was that a gentleman had a bipolar disorder and was found by police in a very disoriented state and unable to explain what he was doing and why he was doing it, but did communicate enough that they knew who his GP was. And so they rang the GP and said, "Is this gentleman your patient, and have you got any suggestions about what we should do with him in this situation? We're a bit worried about him." And the GP said, "Yes, he has a mental health condition. I would be happy to see him straight away. Sounds to me as if he might have gone off his medication or be in a particular extreme phase of the condition. And I'd be happy to see him straight away, or please take him to a hospital and have him admitted." And the man actually made a complaint to the Office of the Information Commissioner, saying that his privacy had been breached because the GP had responded to the police inquiry. And we just referred to that principle in the Privacy Act, and the Information Commissioner was quite satisfied that that was an appropriate context in which to disclose information.
Thank you for that. All right, are there any last questions from the studio audience?
Hi, my name's John. I'm a GP from Oakey. We've had a number of suicides in our community of younger people prior to even seeking care. And the community, we've had a number of community meetings and got people together to try and work out strategies to prevent this in the future. I was wondering if the panel had any suggestions for communities that were looking for more strategies to help people in those situations, you know, prior to seeking care, and what communities can do to try and identify mental illness in those people earlier, and you know, whether there are any evidence for things like Headspace or particular initiatives that actually improved the care for those types of people and actually prevented any suicides.
So I can see you're nodding there, Dale. Did you want to
no,
jump
that's
in?
fine. Look, you know, in an ideal world, we could, you know, if we had community centres, even like a basic sort of drop-in centre for any people who feel disconnected from society, have lost a sense of belonging, anything like that, which we do have in the larger metropolitan and the larger regional areas. So that's one area, that sociological, social contact that people can have, that we seem to be lacking in rural areas. Certainly headspace, we do have a headspace out at Warwick, you don't have one there at all, and yeah, it's a vital service. It's a vital service for children and youth. We do have child and youth mental health team, but that's only once someone has a diagnosed mental illness. As far as that access to services and counselling and all the rest of it, headspace is very vital. Maybe you could lobby, you know, try and... Headspace is in quite a number of centres now, in a lot of rural centres as well. If you find a way to get them there, let me know. I guess probably the schools, perhaps the schools and education, and seeing who's coming into the schools. Are people being... the students being educated on different types of scenarios, difficulties in life, unemployment, which is quite rife and high in rural areas. You know, that overall sense of connectedness of somewhere where they can actually go and get some advice that we've got in, you know, metropolitan areas and regional areas that we don't have always in the rural areas. That's all I can sort of think of there, yeah.
I think looking at individual resilience as well as community resilience, I mean, there's certainly no harm in, especially with the males, trying to get a good mentor for them. I mean, in the public system, you see a lot of broken families with, you know, poor father figures. So trying to get a teacher or a sports coach, some sort of community group where especially the male side can have a good mentor and role model, may build their resilience. Just skills like education, whether it's an apprenticeship or TAFE course, how to manage finances, social skills, all that builds individual resilience. And I think that's probably important from the community resilience point of view. You know, community groups where you get that connectedness and being able to socialise and not be so isolated. You know, I think that's very important. And I think the council's got a role to play in building that community resilience, especially if there's areas of high suicide rates.
These have all been excellent questions, but unfortunately we are out of time for our first case tonight. But if we could all please put our hands together to thank our panellists and our presenter.